It gives me really great pleasure to be introducing Dr. Helen Whitford. I'm going to do a little bit of a bio and then our sneaky presentation, which is part of the reason we've been joined now by the wonderful community of women living with LAM here in Victoria and a few from further afield. So Dr. Helen Whitford graduated in medicine from Flinders University in South Australia. She came to Melbourne to pursue her interest in lung transplantation and is now employed as a staff specialist at the Alfred Hospital here with specific interests in all sorts of things, but particularly orphan lung diseases. And orphan diseases is another name given to rare diseases. So that includes LAM, which I'm not going to attempt to pronounce because I haven't practiced. I can actually type it really well now, which shows you what my day job usually involves, but I'm going to say LAM. And the other reason that we've asked her to speak is that we wanted to present her a special award. So as you guys heard earlier, all about the Elizabeth Pinkerton Memorial Award. So we're presenting 2 awards this year and really excited to present Helen with the 2017 Elizabeth Pinkerton Memorial Award. We took some nominations from the TSC and LAM community, and I thought I'd share with you a quote. But I think the fact that those women with LAM have made an effort on their weekend to come and join us is a testimony in and of itself to Helen's impact on their lives. I'm getting emotional again. I'm going to read this. Helen's clear, genuine and professional demeanour at all times offered me complete confidence in her ability as a leading respiratory specialist on the transplant team. My case was a rare case of a rare condition not seen before in Australia. If it wasn't for Helen's continual drive to source answers for my rapidly debilitating situation, I would not be here today. Helen offered person-centred care and worked with myself and the team to ensure the best possible outcome. I am forever grateful to Helen Whitford. I have a few other quotes here, but I might put them in an article on our website to share with you. But what amazed me is that Helen's reputation preceded her. It was always with women with LAM that have travelled from all over Australia to come and visit her here, and she's shown an interest in not only LAM, but all aspects of their life, other aspects of their medical condition, as well as what it was. Roz is going to make me cry. What it was for them to be diagnosed with LAM later in life. It's a very different experience to present with LAM, even if you have TSC LAM. But as we understand more and more of the science of these 2 conditions, I think more and more our 2 patient communities can come together. So I'm looking forward to working more with the LAM community. But I don't know, did you want to come up and do this with me? Heather? Yes? So although this comes from Tuberous Sclerosis Australia, I think the women with LAM were really excited to join in this today. So did you want to join me in presenting this to Helen Whitford? Do you want to hold that one? Did you want to say something or not? No?
Yes. Sure.
Yeah?
I first met Helen in 2006. We went to a LAM conference in Lura that was organised through the Virginia Northwood Trust. She donated in her will quite a large sum of money to this project, and so we had a conference in Lura that was very successful, and we met Helen there. And that's where the idea of the LAM clinic at the Alfred, that's where the seed sprouted. So it's just wonderful 11 years later that it's been so successful. It's brought all the women in Melbourne and some from other states together. And we have a wonderful support network, and it is lovely to go and see Helen. We often just sit there and have a chat, and I don't know, it's just made the journey so much easier. So so pleased that you got this award.
Thank you very much.
Are very deserving of it. Thank you.
Really good for you there as well.
Thanks.
Are you doing a photo?
Yeah.
Come closer. You got that, Kate? Fantastic. All right. So now you have to earn the bottle of wine now.
Oh, okay.
So Helen's going to talk to us about TSC in the lungs, and that including LAM as well. Thanks very much.
So I tried to make this talk at least relevant to everybody as well as the ladies with LAM. And it is the pulmonary manifestations of tuberous sclerosis, and really this is lymphangioliomyomatosis in almost entirety, although I will talk briefly about multifocal micronodular pneumocyte hyperplasia, which is also occurs but is a relatively benign disease. We really only see it in adult women, with tuberous sclerosis or without. But, and in fact, the majority of my patients don't have tuberous sclerosis, those that have LAM. They have what's called sporadic LAM. It causes a cystic lung disease. It's reported, however, to occur in 35 to 50% of women with tuberous sclerosis by the age of 40. And possibly up to 10% of men with tuberous sclerosis, or males with tuberous sclerosis as well. But it's felt that the male disease is usually asymptomatic, and for a reason I don't actually have any male patients with this disease. There are some rare complications that you can see in tuberous sclerosis of the lung, and again, clear cell lung tumours, aortic or pulmonary artery aneurysms, really rare, and I've not seen any of them. So the main focus of this talk is really about lymphangioliomyomatosis. It's shortened to LAM because no one can be bothered saying it, nor spelling it. Sporadic LAM is basically the same lung disease that you see in tuberous sclerosis, but not associated with tuberous sclerosis. It's felt that there are mutations in the genes, but only in the lung cells rather than, and also some extra pulmonary manifestations such as renal tumours, AMLs can be seen as well. But it's not a germline mutation, it's not genetically transferable. And then there's tuberous sclerosis associated LAM. Both have the same pathological features, so indistinguishable if you look at the lungs under the microscope. It's most common in Caucasians, but it certainly is quite prevalent in Asian populations, and Japan has a very large cohort of LAM. Sporadic LAM's rare. It's supposed to occur in 1 in 400,000 women, so really rare, one of the very rare diseases. But the prevalence is not certain, and we wonder if people have been underdiagnosed. As I said previously, it's supposed to occur in up to 50% of women born with tuberous sclerosis, but it can occur in males as well, and there's some rare case reports of occurring in children. Presentation's usually progressive breathlessness, but commonly recurrent pneumothorax, which is collapsed lung, so air around the lung, so one of the cysts burst. Chylothorax, which is lymph fluid, or an effusion, so fluid around the lungs, and occasionally coughing up blood. You can get some extra pulmonary manifestations, so outside the lung, and these are mainly angiomyolipomas of the kidney or cystic masses, which we see in the abdomen, which are felt to occur in the axial or the lymphatics. And occasionally, and we also see an increased incidence of meningiomas, which are benign brain tumours of the lining of the brain. So the diagnosis is made, it's considered to be made as a gold standard with a lung biopsy. But we've tried to move away from that unless you happen to having surgery to manage your pneumothorax. We don't like to, taking a lung biopsy is not like taking a skin biopsy, it's by no means benign. You know, it has associated morbidity, which means staying extra time in hospital, and mortality. People do die from a lung biopsy, so we don't go there as a standard thing. So the diagnostic criteria have really been based down to definite LAM, probable LAM, and possible LAM. So definite LAM, you have to have a CT scan of your chest, and high resolution just means taking very, very fine cuts. It's a computer program that does it for you. You don't have to think about anything. And a lung biopsy fitting the criteria. But they also said you can be definitive LAM if you've got the CT that is suggestive, but also one of the other things. An angiomyolipoma, chylous effusion, because you don't really see chylous effusions unless you've had trauma or surgery to the chest in the absence of LAM. Lymphangiomyolipoma, which is the abdominal tumours, or a diagnosis of tuberous sclerosis. Probable LAM, and we see a lot of this, is a characteristic CT and an angiomyolipoma. Or we see a lot of possible LAM as well, which is the characteristic CT scan findings, but no other findings. So no abdominal nodes. And we don't biopsy these people unless there's another indication to go into the chest, such as surgery to try and treat a pneumothorax. The pathological diagnosis, it's clear there's nothing else that looks like this under the microscope. So if you get a biopsy, you can be absolutely confident that's the diagnosis. And certainly if we saw a male patient with cystic lung disease, and particularly if they didn't have a diagnosis of tuberous sclerosis, we would never make a diagnosis of LAM without a biopsy. The radiological criteria, the main feature is the presence of cysts, which are basically holes in the lungs. They're small, although they can be up to 3 centimetres, so reasonably large. There's usually multiple of them, and the lung volumes are preserved. So this is what's called an interstitial lung disease. It affects the structure that sort of holds the lungs together, but the lung volumes are preserved, or you get gas trapping, so the cysts are full of air. And there shouldn't be any other features except for perhaps these small nodules, which is this multifocal micronodular pneumocyte hyperplasia, and I've only got a couple of patients who have that in as well. This is a picture of a high-resolution CT chest. You can see whether lots and lots of these holes, round, multiple cysts, and that is a CT scan that is compatible with LAM. The main differential diagnosis in an adult population is of emphysema, but it does look quite different. You can see that the cysts aren't so round, they all blend into one each other, and this is really just destruction of the lung architecture from smoking. But, you know, patients come to us, is this LAM in the right age group, females in their 40s? And sometimes it's not, sometimes it's emphysema. Other points in the diagnosis is that if you've got tuberous sclerosis, it's LAM. If you've got cystic lung disease, and particularly if you're female. It's very exceptional in males without tuberous sclerosis, and again, you know, even with tuberous sclerosis, we really don't seem to see the males, and whether or not they're being out there in the community being diagnosed with emphysema, I don't know. And so really the diagnosis is at the exclusion of other causes of cystic lung disease, and there's a huge list of things that cause cysts in the lungs. So we would weigh all those up, and really the CT gives us a good guide. This is just a sort of small list of what other cystic lung disease is. Won't go into those in detail today. So how do we treat it once we make the diagnosis? There's lots of general advice: don't smoke, eat well, join a support group. 33% of patients will have a pneumothorax or a collapsed lung at presentation, and about 2/3 of people with LAM will have a pneumothorax at some stage in their course, and that's this collapsed lung. Some need oxygen therapy, sometimes bronchodilators, which are things like Ventolin, and there's some longer acting versions help as well. Vaccinate against the flu and against pneumonia, and pulmonary rehab, which is a sort of structured exercise program. Because this is a disease that we see really primarily in women, there was a whole lot of thought, well, let's block oestrogen, because that's the thing that's different in women. Women have oestrogen. So is that a good idea? And there was a long trend. When I first got involved with this disease, apart from transplant, treatment was hormonal manipulation. There are no randomised controlled, placebo-controlled trials, and really the evidence is that it makes absolutely no difference. And particularly if you give oestrogen blocking drugs, which are used in breast cancer, you just make people feel absolutely awful and premature menopause, and there's no benefit. So really, the current recommendation for this is that there is no indication for hormonal therapy, but this is a conditional recommendation in the basis that the levels of evidence are very low. There aren't any randomised controlled trials, so we don't know for sure, but we don't believe it makes any difference, and it certainly makes people feel terrible. So we get on to the MTOR inhibitors, and you've heard a lot about MTOR inhibitors today, so I just really wanted to talk about the trial because this is an amazing trial that really took a lot of effort to get done. This is a rare disease, and to be able to do a randomised controlled trial, it's the only randomised controlled trial ever done in LAM. It was investigator-driven by Frank McCormack from the US. Pfizer really only supported for the cost of study visits and some drug, and it utilised centres in America, Canada and Japan. They made sure they wanted a really likely diagnosis, not possible LAM but probable LAM. And they developed a blood test which looks at vascular endothelial growth factor. And if it's high, then that increases the probability that this is LAM, and that's really been proven in a number of subsequent trials to actually show that that's a very good test. Unfortunately, we don't have access to do the test in Australia at this point. Otherwise, you had to have had a biopsy or have one of the other contributing factors to get at least a probable diagnosis of LAM. They did exclude in this trial people with chylous effusions, so the lymph fluid in the chest. 89 patients seems like a small number really when you look at those cardiology trials where there's 4,000 patients in each arm, but 43 and 46 was a pretty good trial for LAM, and followed the patients 12 months on drug or placebo and then 12 months follow-up. I think what's really interesting in this trial is if you have a look, the number of people who actually completed the 24 months was really low in both arms, mostly because people anecdotally heard that those who were getting the active drug were doing better, and so they all wanted to get access to the drug in some way, and very few people stayed in the randomised part of the trial. This trial was positive. There was a reduced decline in lung function. There was a mean change from baseline was improved with the active arm, and a whole lot of other secondary endpoints were also positive. So rate of decline was not 12 mils of FEV1, which is a measure of lung function, versus 1 mil in the sirolimus, and that's strongly positive. It reached statistical significance, and as a result, this was considered a positive trial. The drug, however, was never PBS funded, which is the pharmaceutical benefits funded for LAM in Australia, because no drug company was prepared to spend the large amounts of money to get the drug funded for such a small number of patients. Fortunately now, sirolimus is available through the PBS without any restrictions. Also, prior to that, we had access to the drug through the generosity of our hospital pharmacy. We've been through the adverse events. I must say, my experience is that the mouth ulcers are really about the one thing that people complain about from time to time, and by really aiming for a level of somewhere between 4 and 6, the clinical trial aimed for 5 to 15, which is very high levels of drug. We've aimed more 4 to 6, and really we don't see a lot of serious adverse events. So it improved quality of life. There was some debate about whether you were older and postmenopausal had less benefit, but that's not quite true. There's certainly, these people also benefit. Some further evidence and some evidence with everolimus also shows that both drugs are equally efficacious, sort of down the track. So this is just our early experience, which is where we sold it to the pharmacy board at the Alfred, was to show that if you started from a really low baseline, it didn't make a lot of difference. But if you were better, this is the decline leading in, and this person stopped their sirolimus here, but everyone else improved. And that's also shown with oxygen transfer. This is what DLCO stands for. It really basically means oxygen transfer across the lungs. Again, improvements, not much change if you're starting from a low baseline. So, the current treatment recommendations for mTOR inhibitors in LAM are that it is strongly recommended that patients who have abnormal or declining lung function are given sirolimus or everolimus, whichever you can access. It's one randomised controlled trial, but I think the evidence in this sort of rare disease is there, and they certainly seem to do well, and it's well tolerated. It's also recommended for patients with chylous effusions, which are difficult to manage, so the simple drainage doesn't work. But again, no randomised controlled trial, so conditional on low level of evidence, but really does work, and it's better than the alternative treatments, as I think Ros can attest. So just other agents, just to briefly mention, bronchodilators are used, and there is some airway reversibility, sort of asthma component seen in LAM, and we do use bronchodilators. The role of inhaled corticosteroids is less clear. There's a whole lot of thought about the statins, which are the things like the lipid-lowering drugs, simvastatin, atorvastatin. No real benefit, to be sure. We certainly see that the mTOR inhibitors can put your cholesterol up, so maybe that helps. Doxycycline was all the rage for a little while. There was one case report saying that someone got better taking doxycycline. They probably had a chest infection. But 2 trials done, both negative, and it's not recommended. So a little bit about the complications, because I think this is where we sort of sometimes meet people. Pneumothorax, it's often the presenting thing. As it said, in a third of cases, people present with a collapsed lung. It's the first time anyone ever does a chest x-ray or ever does a CT scan and they find the cysts. But the treatment's the standard for a collapsed lung, put a chest drain in and re-inflate the lung. If, however, it recurrently collapses, then pleurodesis, which is basically putting some talcum powder and sticking the lung to the lining of the lung. That adds to complexity if you ever need lung transplantation down the road because of increased risk of bleeding because there's now scar tissue. But it stops the lung collapsing, and there's also concern, obviously, on flying because of the changes in pressure. Chylothorax, and we used to struggle a lot with this. I think Ros was fortunately the last case where we had a terrible time, where we did a lot of these things. She was in hospital for, I think, 5 months. Draining this effusion, fat-free diet. Now, if you've ever eaten a fat-free diet, you don't ever want to go back there. We go low-fat diet, but fat-free is really unpleasant. And total parenteral nutrition, or being fed into a vein, not eating at all. We did all of these things. We tried to stick the lining of the lung together, then we actually stripped the lining off the lung, and it kept coming back. We then gave her sirolimus, and here she is, quite a number of years today, off oxygen and looking good. So I think, you know, this is a real story of, this is a drug that really changes things. It doesn't reverse the holes in the lungs, but it does stabilise the disease, and it does sort of improve quality of life and quantity of life and really functioning for the long term. Briefly about lung transplant, just because it is the sort of the final treatment. Really only for people who are at end-stage disease. Lung transplant's not perfect, so we wouldn't want to see anyone who was too well. Just to have a little gloat about the Alfred lung transplant program, we're certainly doing better than the 1-year survival is 86% from the international registry. We're at 100% and certainly better overall. But even so, 5-year survival is 75%. It's by no means perfect, and people die of infection and rejection. So particular things, if you've had previous surgery on your chest, increased risk of bleeding, and we've certainly had some torrid tales of large amounts of blood product being required. Briefly to mention multifocal micronodular pneumocyte hyperplasia. This disease has terrible names. And really this is just solid ground glass or solid. So ground glass just means it looks like crushed glass and you can sort of see through them. Lots and lots of little nodules that shouldn't be there in the lung fields. These tend to be benign, don't tend to progress, and I suspect they represent perhaps a tuber type picture. Don't seem to, more common in tuberous sclerosis, though they have been reported in sporadic LAM, and they don't seem to do anything. There's no guideline at present. Should we screen everybody with a diagnosis of tuberous sclerosis for the pulmonary complications, particularly the women? There's no guidelines at all. No one says. High resolution CT chest is great. However, because we believe this disease may develop later or progress, you don't want to do too many CT chests, particularly in young women. There is evidence, although it's a small increase, but a small increase in breast cancer with recurrent CT chests. There's about 100 times the radiation of a CT compared to a chest X-ray. They have developed protocols where you can do low-dose CT chests, but they don't actually give you the answer because it doesn't give enough definition for this problem. It works for things like, you know, major changes, you know, fluid, etc., pneumonia, patchy changes that you want to see if things are changing. So an HRCT chest, perhaps at baseline, 1 CT is probably all right. Lung function, if you can do it, is an excellent way, both looking at spirometry, which is just how much you can blow out in a second, how much you can blow out in total, plus oxygen transfer, breathe some gas in, and then carbon monoxide in very low doses so that we don't kill you. And then when you exhale, you work out how much has been transferred across the lung bed and how much is exhaled. And that gives us a very idea, but it requires a lot of cooperation, so it's not suitable for all patients with a diagnosis of tuberous sclerosis, but certainly for those that can cooperate. It's a safe, easy screening test and can be done on multiple occasions without harm. So at the moment at the Alfred, we have a LAM clinic, which we run every 6 months. We would do a medical review, a 6-minute walk test, just to assess their exercise capacity and lung function, including gas transfer on those occasions. Patients who are taking sirolimus, we often see between or outside the LAM clinic in the respiratory clinic. And we're currently having discussion. I've certainly got the renal team on board to try and run a multidisciplinary team clinic at least a couple of times a year, where we get, for those patients with need to see multiple doctors, only have to come to one place at one time. And I think that that's a model that certainly works very well. In lung transplant, we have a kidney doctor, we have an endocrinologist to manage diabetes, we have a rheumatologist. So getting the patients to come once and see multiple doctors on an occasion, particularly for those who work, but even for families who work, it's really a nice way to do it. Not up and running as yet, but we hope that's the hope for the future. So I'd like to thank you once again for this award. I'm really honoured, and it's an area which I think we can do better. But I've been very pleased and proud to look after such a wonderful group of patients. Thank you. Thanks, Roz.
Yeah, on behalf of everybody with LAM, we'd just like to say thank you so much for supporting us on our journey, all of us. You've just been a wonderful support, so clear, so just sort of the ground person that we needed to see and keep us going.
Thank you.
So thank you.